We'll talk about different types of assessment techniques and safety in the clinical setting. Well, when we're doing an assessment, we're using all of our senses. We're going to be able to smell things, see things, touch things, and what we hear, and we all collect all that data and use it in our physical examination documentation. There are four different types of assessment techniques that we are going to use: inspection, palpation, percussion, and auscultation. We first use inspection on the initial laying eyes on the patient. When we first meet them, we're looking at their mental status. Are they alert? Are they oriented? And then how do they appear? Do they appear like they're well nourished? We're doing a general survey in the very beginning. As we proceed through the exam, we will use inspection first, always. We're always going to look first. It requires good lighting, so cut that light on, adequate exposure of the extremity or body part, and we may use instruments to help, like an otoscope or an ophthalmoscope, a pen light, or a nasal or vaginal speculum if that is what we are inspecting. Now, palpation is basically touching. We're going to press gently with our pads of our fingers. We're feeling texture, temperature, moisture. We're feeling for organ locations. Any swelling? Do we feel vibrations, pulsations, crepitation, which is little crackling sensations underneath your fingers when you're feeling? Any rigidity or spasticity? Any presence of lumps, masses? Is there any tenderness or pain? We should do it slow and systematic in a rhythmic manner. We start in a light palpation, which is just gently pressing, and then we can use a deep palpation on the patient's abdomen and feel for organs. Bimanual palpation is used for certain body parts, like feeling inside the vagina while pressing down in the abdomen to feel for the ovaries or uterus. So that is more of an advanced assessment technique that, as bachelor prepared nurses, we may not use that very frequently. So we'll use our fingertips to just feel for the skin texture, swelling, pulsing, any presence of lumps. We use our fingers and our thumb to detect position, shape, consistency of organs and masses. When we use our hands and our fingers on, because the skin here is thinner than on the palms, we use the back of our hands to feel for temperature. That's the best way. And then the base of our fingers or the ulnar surface of the hand is best for vibration. So we will use that on the back when we are doing a lung assessment. Percussion is when we use our fingers to tap on the person's skin with short, sharp strokes, like it is here in this picture. So we're going to tap, tap, tap on top of that fingernail to try and get a sensation or a audible vibration that we can hear. It helps detect if there's superficial masses underneath or if there's hyperinflated lungs. We can also use a reflex hammer to help elicit deep tendon reflexes. When we do percussion, we are getting some sounds more than likely. So we are listening to the amplitude or the intensity, a low or a soft sound, how the pitch is, and number of vibrations per second, the quality, and the duration, length of time that it sounds. So more air produces louder, deeper sounds compared with a less air or denser structure. Variations occur in clinical practice based on individual anatomical differences, so it just depends on the patient as well. The next step in assessment is auscultation. So we are listening to sounds produced by the body. We're usually going to use our stethoscope for this. It does not, it magnifies sound somewhat, but it mostly blocks out all other sounds. You want to make sure you have a good seal on your diaphragm or bell on the patient's skin. If you have any opening underneath there, you're not going to hear hardly anything, or you're going to hear room noise, and that's going to make your assessment very poor. So make sure that you have a good quality stethoscope and that it fits in your ears good. You're going to use the diaphragm for high pitched sounds, the bell for deep, hollow, soft pitched sounds, and then make sure your stethoscope is turned on. So you have to turn it to the side you're going to be listening to. When you're doing an assessment with your stethoscope, you want to eliminate extra noise. That includes asking your patient to be quiet during the exam so you can hear. Otherwise, you'll be hearing the vibrations of that patient talking and you won't be able to hear anything. Turn the TV off, have them turn their radio off, whatever it is, eliminate noise. You want to make sure your stethoscope is not freezing cold when you go to put it on your patient's chest. You don't want to listen over really hairy body parts if you can, because that kind of creates space for extra noise to come in. Never listen through a patient's gown or clothing. Don't do that, please. Don't do that. You're going to hear too much static and other noises that are not patient sounds. You don't want to make artifacts with that. And then avoid your own artifact. So your own artifact would be like touching the stethoscope. You see this lady here is about to create her own artifacts by touching the stethoscope with your shirt or your hand can create artificial noise. Prepare your examination room to be warm, comfortable, quiet, and well lit if possible. Avoid distractions and interruptions. So you will refuse distractions and interruptions when you are performing an assessment or an interview with a patient. You want your lighting to be natural or able to adjust it. Your exam table should be easy to access and be able to at least raise the head of the bed to 45 degrees. You can use a bedside table or a countertop for extra equipment or your documentation resources. And you want to be in a seated position, in a comfortable position next to the patient during the exam. We use standard equipment for screening, like your vital signs equipment, do hand hygiene, use PPEs if you need it, and then measurement of vital signs and a scale. We'll do height. We will do blood pressure. Pulse oximeter can also be included, but it's sometimes not necessary depending on your setting. Other equipment that we use for assessment techniques includes the use of an otoscope to look into the ears, an ophthalmoscope visualizes the eye structures, a pen light to shine light on things and to look at the constriction of the pupils during an eye exam. And then you can use a pocket vision screener, which is like a Snellen chart, but it's called a Rosenbaum chart and it's much smaller and it helps screen for near vision disorders. We can use skin calipers to measure, fat percentage of someone's body. We may use a skin marking pen, like a surgical area, or dermatology to circle things that we need to pay attention to. A tuning fork helps with hearing exams. There's nasal speculums, tongue depressors, cotton balls we will use. We'll use tape measures, rulers, a sharp and dull object, reflex hammer, and then there's other special things that depending on your unit. It's important that you use clean instruments and items before you use them on your patient and clean them after you use them. There should be a clean area of your working space and a used or dirty area of your working space. It should be separate and not together. You will use your clean instruments and then you will place in the used area, throw it directly into the trash when you are done with something that goes in the disposable area. The reason why it's so important to make sure that your equipment and your area is disinfected prior to using and after using is to avoid the transmission of infection. We don't want patients to get hospital-based or community-based nosocomial infections that leads to the development of resistant infections like MRSA and VRE and other multi-drug resistant organisms like TB. Hand washing is the single most important step to decrease the spread of microorganism bacterial viral transmission. Hand hygiene must be completed before and after patient care or after contact with blood, body fluids, secretions and excretions, after contact with contaminated equipment and after removing gloves. So these are all the specific steps of when you should do hand washing. Standard precautions should be used with every single patient. That's hand hygiene, using your PPEs appropriately, respiratory hygiene and cough etiquette, using your PPEs, precautions in the clinical setting. There's standard precautions, there's extra precautions we can use if someone has an active infection, whether it's contact precautions, droplet for respiratory type or infections and airborne precautions that we could use in the hospital setting. So pause your screen and take a look at this question to see what you would do when preparing to do a physical exam on a patient who has end-stage HIV positive status. What should the nurse do for self-protection? So you would have to know a little bit about disease process to know what sort of self-protection you would need for yourself. So hopefully you chose the correct answer was number 4, to just wear your gloves while you're doing a full physical exam because you may come in contact with wounds or body fluids if you were doing an exam. So you would just wear gloves and then you would have washed your hands before and after. That's the only thing you would have needed to do. There's no risk to contracting HIV. Um, Unless it's a blood-borne pathogen, so you would only need to wear gloves. For our general approach, we want to make sure that we can help reduce any patient anxiety because they are in an uncomfortable position of having to be examined and being in a hospital environment. We want them to feel more comfortable, and the data we gather will more closely describe the person's natural state of mind as well. We'll do hands-on things with assessments like measurements, vital signs. We want to have the patient change into an exam gown to maintain privacy and respect. Wash our hands, provide explanations. Well, this sounds a lot like the QUIPES acronym. Knock, wash your hands, introduce yourself, identify your patient, provide for privacy, perform we've already performed hand hygiene, provide explanations. We're going to tell the patient what we're doing before we do it. So we want to always do that. And then we will summarize our findings for the patient. So basically letting them know what we found. There are different positions that we can place patients in for examination. Let's see. So we have semi-Fowlers right here. Okay. We have lithotomy here at the top. We have just sitting upright here with the legs dangling off the table. And then we have left lateral or Sims position here. Lateral position. This is just the opposite view of the lateral. We have prone up here, face down, supine, face up, and then we have a knee flex position with this one. This is what we're going to put our patients in for their abdominal exam. We have to provide care in consideration of our patient's developmental stage is more meaningful than their chronologic stage, their stated age. We position them, prepare them, and sequence them across all the life cycles from infants to toddlers, preschoolers, school age, adolescents, and the aging adult. They all have special needs and circumstances that we need to tailor our skills towards them. And hopefully, we can increase their comfort with a positive memory of healthcare providers, especially for children. And if you see this little boy, he is playing with the equipment. And that's a great strategy to get your assessment in for children is to allow them to kind of play with your stethoscope before you use it. When someone who is sick, you may need to alter positions during the exam. For example, in a med surg environment, these patients may be bed bound. They may not be allowed to get up. They may not be able to get up. They may be too sick to sit up for you for a lung exam. So we'll have to learn how to adapt our assessments to get the data that we need with the position that they're in. Or can we turn them on their side to listen to lungs instead of the typical sit up for me? So we may have to do that. Sometimes we do just um, a database appropriate to just their specific problem, and then we may need to come back later to finish other assessments if the patient could not tolerate a full assessment.